This concludes the Ophthalmology Hall of Fame section of the opening general session. And to introduce this year's Binkhorst Lecture, please welcome back our new ASCRS President, Ed Holland.
ASCRS established the Binkhorst Lecture and Medal to honor Cornelius D. Binkhorst for his pioneering work in ophthalmology. Each year since 1975, ASCRS has conferred the Binkhorst Medal on an individual whose career has made significant contributions to the science and practice of ophthalmic surgery and established that person among the world's most prominent ophthalmologists. Ladies and gentlemen, I have the pleasure of presenting Dr. Abhay Vasavada. Congratulations.
Well, I received travel support from Alcon Laboratories, but have no financial interest in this presentation. I wish I could tell you how honored and privileged I feel today standing in front of all of you, my colleagues and friends. I sincerely thank ASCRS and Binkhorst Committee for considering me worthy of this honor. I must say, some of the most worthy goals come to us, guised as nothing more than a small opportunity. My small opportunity came to me when I started my private practice in Ahmedabad, a city that I had never grown up nor studied in. At that time, in 1984, an ophthalmologist dealt with every problem of the eye. But I was convinced that I wanted to take up one entity and try to excel at it. And quite unconsciously, I set a trend in my part of the world when I took up cataract surgery as my specialty. I was determined to try and master many challenging cataract scenarios. And we have plenty of these in our part of the world. In time, my determination was rewarded. But as I began to make my mark as an adult cataract surgeon, I saw myself faced with pediatric cases also. Parents came to me with a lot of faith and expected the caliber I was delivering for my adult cataracts. Taking this as yet another challenge, I set out to do my best. But it took only a couple of cases for me to realize how totally I had underestimated the problem. My team and I were not geared for it. Moreover, it actually disturbed the smooth rhythm of my adult practice. But somehow, I couldn't turn away from these children. And when I looked at the magnitude of these problems, I found that India alone is home to so many blind children. And of these, 10% were due to cataract, unavoidable and of course treatable. And that was a calling I could not ignore. And ladies and gentlemen, I made a choice. And I'm very grateful that I'm involved in something I feel profoundly important. As it's been said, determine the thing that can and shall be done, and then we shall find a way. And to find my way, I had to identify and determine the challenges unique to the pediatric cataract management. So as we formulated, it was very obvious to me that surgeon alone is not going to suffice. Building a team and try to deal with all the aspects of pediatric cataract management would be very necessary. Here, a pediatric coordinator is a vital link in maintaining the communication with the parents. And the parents are crucial team members of the entire endeavor. Having set this team, we decided to meet with surgical challenges and try to overcome the way I saw them. As an adult cataract surgeon, first I had to conquer the phobia of touching the posterior capsule, because posterior capsule surgery is an integral part of the strategy. Then we began to standardize the surgical protocols. It's very obvious to remove the stimulus deprivation due to cataract. But the key question is, when is a surgery safe to undertake? In my experience, the children are brought quite late to us. As you can see here, 60% are about 2 years when they first present. But if brought earlier, a unilateral cataract can be operated at 4 weeks, and a bilateral cataract at 6 weeks, and this can be considered quite optimal. In trying to formulate surgical strategy for lens removal, we took a platform from the adult cataract surgery. That means maintenance of the anterior chamber at every point of time during the surgery, and here, by manual techniques, remain the sheet anchor. Posterior capsule management is not only unique, but very vital for these eyes. Posterior capsular axis affects the clarity of the visual axis, gives stability to the intraocular lens. The way a surgeon manages the posterior capsule decides the fate of the child, and in my opinion, the fate of his practice. And of the various techniques reported, manual PCCC remains the gold standard. Anterior vitrectomy also has become an integral part of small children's surgery. Triamcinolone helps us to ensure adequacy of vitrectomy. Pars plana vitrectomy combined with posterior capsulectomy remains another good option. After intraocular lens is placed safely in the bag, this is performed. Giving a stable and child-friendly optical correction is mandatory to achieve and accomplish the ultimate visual goal. While aphakic glasses is a consideration for bilateral cataracts, quite often it's cumbersome and provides compromised vision. Contact lens use is expensive and impractical in many parts of the world, and is largely dependent on parents' compliance. In my experience, intraocular lens is a better option to attain a better or optimal visual outcome. We then began to standardize the follow-up protocol to ensure a stable eye and a good visual performance. And we did it of regular intervals. Examination under anesthesia, EUA, remains a mainstay. It enables the battery of evaluations to be performed at each visit. The purpose here is to identify any potential problem so that we can deal with these problems well in time. Here, as you can see, a rapid development of a fierce obscuration of visual axis is dealt in time. Laryngeal mask anesthesia has made this examination a lot safer. At each visit, a detailed examination is carried out, its documentation is done, and optical refractive correction and amblyopia therapy are ensured. But to enforce this follow-up, I face another hurdle. India, being a developing nation, genesis of these congenital and development cataracts remain in malnutrition, maternal health issues, low birth weight, and prematurity, primarily due to poverty and lack of awareness. Quite often, parents come from poor socioeconomic background and they have little or no money to pay for the surgery, let alone to maintain the link up for the follow-up. And so, many of them did not bring the children back to us. I looked at the other centers of repute to see how they addressed this problem of follow-up. And I must say, all these centers are doing a commendable job in pediatric cataract management. But I found that these were the institutions with infrastructure and resources provided by the government or by public funding. Well, I had started and undertaken this as a private practitioner. To ensure an optimal visual performance, we then began to give financial aids for the travel, subsidize the surgery to suit their pockets, and provided free follow-up examination under anesthesia. All these to make sure that we bring these patients back for follow-up, and therefore we will try to ensure good anatomical and functional outcome. We also set a culture where a pediatric coordinator would contact the parents to make sure that the advised therapy is being followed up properly. At each visit, the child would receive gifts. Well, this system